Alrighty, so we're going to be going over Chapter 26, Nursing Care for Patients with Heart Failure. Our first few slides, we have our learning outcomes, so describing the pathophysiology of left and right-sided heart failure, defining acute heart failure, listing the causes of acute and chronic heart failure, identifying signs and symptoms of acute heart failure, assisting in planning nursing care for patients that are undergoing diagnostic tests for heart failure. Additionally, we want to explain medical treatments used for acute and chronic heart failure, assist in planning nursing care for our patients with acute and chronic heart failure, then assist in planning and teaching for patients with heart failure and for their families as well. Our chapter concepts that we'll be going over: caring, collaboration, comfort, fluid and electrolytes, oxygenation, perfusion, and then teaching and learning. All right, so here we go. Alrighty, so heart failure is a clinical syndrome that's going to develop when our heart cannot pump enough blood to meet our body's oxygen and nutrient needs. An older term for this was congestive heart failure, but now we use just heart failure because we realize congestion's not always present. Especially in our early disease process, some of our patients just have low cardiac output symptoms. Okay, so in our heart failure, we know that we have a decrease in our heart's ability to pump. So common causes of this are coronary artery disease. This is going to be our most common, that reduced blood flow is going to cause heart muscle ischemia, and that's going to weaken our pump ability. Cardiomyopathy, so we have that structural damage, and then the enlargement of the heart muscle, that's going to reduce our contractility. Hypertension, so our heart must pump against that increased resistance. And this can happen over several years, so that muscle is thickening and then eventually weakening. It can be caused by heart valve disorders, so valves that are leaky or narrowed, stenosed, that causes our heart to work harder, pumping that blood forward. And then caused from a myocardial infarction, so that dead heart muscle can't contract. So we have that permanent loss of ability where that muscle is affected. I want you to realize that heart failure is not a sudden problem. Okay, this is going to develop after conditions begin to damage and overwork our heart muscle. Okay, so it's the end result of long-term damage. Alrighty, getting into the pathophysiology. So under normal circumstances, each ventricle is going to pump equal amounts of blood. And that balance is going to keep moving our blood smoothly through our lungs and throughout our body. So, however, as one ventricle becomes weak and overloaded, our heart's not an effective pump anymore. Okay, so blood begins to back up, and then our pressures will increase behind that failing ventricle. Okay, most commonly, it's our left ventricle that is going to weaken first because that's having to work against higher pressures to pump the blood to the entire body. Okay, and our heart being a two-pump system, the failure of one side usually leads to the failure of the other. So as one side fails, that pressure builds, and then the other side is working harder, and that increased workload on both sides leads to that progressive failure. Okay, so you're not staying in left-sided heart failure forever. Eventually your right side's going to fail too, so you're going to have both sides failing. Okay, so this slide's going to focus mostly on our left-sided heart failure. So our afterload, that's going to be our force generated, or the resistance against that left ventricle that it must overcome to eject our blood out into the aorta and through the aortic valve. Okay, so think of this as the pressure the heart has to pump against. All right, our afterload can be determined by a few different things. So that peripheral vascular resistance, so that's the pressure that's within the aorta and our arteries, and then that stiffness of them. Okay, so when our afterload increases, we have our left ventricle working harder. Alrighty. So hypertension, that can be a major cause that can significantly increase our afterload. So as that left ventricle isn't pumping effectively, as it's not pumping effectively, our blood is backing up into our left atrium, and then that pressure moves into our pulmonary veins, and then that causes fluid to leak into our alveoli. Okay, so we get that our alveolar edema resulting. Okay, so this is our pulmonary congestion. Alrighty, so things that you would see in your patients as this is starting to back up into their lungs. They may complain of dyspnea. You may hear crackles. They're having to find a comfortable position to be able to breathe. They feel like they can't breathe whenever they're laying down. They can have decreased O2 sats. Okay, so I want you to know that your hypertension is going to be a major cause of that afterload increasing. So here's an image from your book that's kind of showing the left-sided heart failure, how that relationship between your heart and lungs is working. So as your left ventricle is failing, it's not pumping that blood forward as well as it could. So we're not pumping blood forward into our systemic circulation. So that blood backs up from the left ventricle to your left atrium. From there, our pressure is increasing in our pulmonary veins, and then we're getting that fluid leaking into our lung tissue and our alveoli. So that's that pulmonary edema. Okay. Next, we're going to talk about the right-sided heart failure. So our right-sided heart failure is most often caused by left-sided heart failure. So when that left ventricle fails and the fluid is backing up into the lungs, our right ventricle must then start to pump harder against that increased pressure. So over time, that extra workload is going to cause your right ventricle to hypertrophy. It weakens the right ventricle, and then we eventually get to that right-sided heart failure. So this progression can be referred to as a cor pulmonae. So that's a Latin term. If we break it apart, we have core, so heart, pulmonae of the lungs. So you're having, like, literally translates as the heart of the lungs. So we're getting a heart problem from our lungs. That's where that's coming from. So that backward buildup of blood begins to go to our systemic blood vessels. Okay, so we have left ventricle backing up into our left atrium, backing up fluid into our lungs. So our right ventricle is having to work harder, and that's starting to fail, causing our blood to back up into our system. Okay, and that's where we're getting that peripheral edema to start resulting. Okay, so we're having that extra fluid that's backing up expand into our tissues. A simple way that I think to like break this down is your left-sided heart failure. So your blood is backing up and it's causing a traffic jam in your lungs, which is then going to cause your right side to jam up and cause a traffic jam into, your systemic circulation. So that's what this picture from your book is showing, our right-sided heart failure. So we have that back up into our systemic venous circulation, and then we have that increased venous pressure to try to force fluid out of our blood vessels, and that's leaking into the surrounding tissues. So our fluid's going to accumulate in our dependent areas, so areas like our feet and ankles, lower legs. In our bedridden patients, it can show as accumulating in their sacrum. If it accumulates in our abdomen, we get ascites from it. So our body's doing the best it can to try to compensate, and those compensatory mechanisms are designed to try to maintain your cardiac output. So as that cardiac output starts to drop, our body is going to try to compensate, maintaining our blood flow to our vital organs. But this is only a short-term solution, so this is going to eventually cause worsening heart failure over time. So this is when you're in these compensatory mechanisms, your body's in like survival mode, so it can only do these things for so long. Okay, so this slide is talking about the things that we're going to try to do to maintain that cardiac output. So as it's dropping, we want to try to maintain blood flow the best we can to our vital organs. So our sympathetic nervous system, it's going to help increase our heart rate, but in turn, this is going to increase our cardiac oxygen needs. Okay, so increased heart rate is going to increase that myocardial oxygen demand. Okay, so our heart's working harder, it's becoming more stressed. Our renin, angiotensin, aldosterone system, and then our antidiuretic hormone, they're going to work to save water. So by doing that, we are causing sodium and fluid to be retained. So this will increase our blood volume, but it's also going to increase the preload on the heart. So it'll initially help to improve our circulation, but we know that that extra fluid volume is going to eventually increase the workload on our heart and lead to things like pulmonary congestion and then our peripheral edema. The chambers of our heart will start to enlarge, and that'll help them hold more blood and increase our stroke volume. But over time, that dilation is just going to stretch them too much, so we don't have the elasticity, and it becomes less efficient. And then our muscle mass will increase. So this would be your hypertrophy. Okay, and that hypertrophy is going to thicken our heart muscle. So initially the thickening will help, create a stronger pump, creating more force, but that stiffness is going to decrease our ability to fill. Okay, so these are all short-term things that'll eventually lead to worsening long-term effects. The what do I want to say, analogy that I remember for like the compensatory, how to think of those is that like whenever you're driving a car and you're running out of gas, you can push the gas pedal harder, but it's not going to help you have any more gas. So it might help you get to where you need to go quicker initially, but you're not going to be able to get there long term, if that makes any sense. Okay, so acute heart failure is also referred to as pulmonary edema, and this is occurring when we have severe fluid congestion that's rapidly flooding into our alveoli. So this is life-threatening. This is a medical emergency because instead of our alveoli filling with air, they're being filled with fluid, and that gas exchange cannot occur. So your patients can express this feeling as they feel like they're drowning because they are drowning in their own secretions. Okay, that's a pretty accurate statement there. So what's happening here, physiologically, our left ventricle fails suddenly, and that pressure increases our pulmonary circulation, and then that fluid that is being backed up is being pushed into our alveoli, and gas exchange is not occurring. So we develop hypoxia. Okay, so your patients that have pulmonary edema, which we know it's a medical emergency, they're going to look very, very anxious and restless. And your patient that looks restless, they might be kind of, so what that looks like is they're like kind of fidgeting around in bed. it seems like they're always looking for something that they can't find. They might be confused trying to get out of bed. They might be picking, um, and that's just that hypoxia. Okay, so restlessness is most often our first sign of hypoxia. Since this is life-threatening, I want you to know what things to look for, like what your patient's going to look like early versus, your more later signs. So earlier, you're going to see that sudden severe dyspnea. They feel like they can't breathe. They can be tachypnic, anxious, and restless. They'll have that increased work of breathing. So that's what they're going to look like early. So as this is suddenly happening, okay, this is whenever you're calling to get your help because you see this, patient. You can literally start to hear it happening because they have that, all that fluid building up. Okay, so later, as this has developed, what you're going to see is they may have pink frothy sputum. They can be cyanotic. They will have crackles whenever you're auscultating. They can have confusion. So this is where we're getting to that respiratory failure. Okay, so whenever you see words like pink frothy sputum, think your pulmonary edema, your acute heart failure. And then in your patient that, like for test questions, restlessness should be a key, like kind of a red flag to you that this patient's becoming hypoxic. Okay, so our classic signs and symptoms, that pink frothy sputum, and by frothy, I want you to think of the best example I have for this is coffee, kind of, on the top of your frou-frou coffees, we have that bubbly white, foamy look, only in this case, it's going to be pink. Okay, and that's going to be from where that fluid that's flooding into your alveoli is mixing with small amounts of blood. Okay, rapid respirations with accessory muscle use, the severe dyspnea and orthopnea, crackles, it can be wheezes that you'll hear from the air trying to go past those fluid-filled areas, the anxiety and restlessness from hypoxia, and then clammy cold skin. So with this, I want you to think when you walk into a patient's room, you see these things going on. You want from that possible orthopnea, you want to try to get them into a high Fowler's position and position to where they are expanding their lungs and able to take good deep breaths. Okay, that's gonna be your first, initial whenever you walk into the room. Yes, we want to put oxygen on them, but for them to oxygenate well, we need to get them into a good position. So a question like this, whenever you suspect pulmonary edema, your priority action will be that positioning for your patient. Okay, so to diagnose acute heart failure or pulmonary edema, we are going to need an ABG, and that's going to help us evaluate how well our oxygen is moving into our bloodstream. So early on, we're going to expect to have a decrease in PaO2 and then a decrease also in our PaCO2 from the hypoxemia, which is your low oxygen in your blood, and then from hyperventilation. And then later, as we're progressing, as our pulmonary edema is progressing, we'll see that we have respiratory acidosis. Okay. So our pulmonary pressures, we can monitor these at a higher level of care. So our ICU, we have special like catheters that we can place to monitor these pressures. But what I want you to know about them is that pulmonary artery pressure is going to increase due to that fluid backing up. So pulmonary pressures are going to confirm that pulmonary congestion. And then for x-rays, this can help you visualize the fluid in the lungs. So on a normal x-ray, our lungs should look nice and black and clear, but as we get fluid, they'll appear more white, okay? Um, so listening to our patient, we're going to hear crackles, but like the x-ray is going to help us see how much fluid and where that fluid is. Okay. Alrighty, next we have therapeutic interventions. So we talked a little bit about the immediate treatment whenever you walk into this room, what you want to do. So you want to position your patient. So this says place in a semi-Fowler or Fowler's position. We want to place them to where they're sitting up well, able to get a good deep breath. We want to improve our oxygenation. That is our main goal here. So main goals for our therapeutic interventions is improving oxygenation, reducing the fluid in our lungs, and then to decrease the workload on that left ventricle. So overall, we want to treat the underlying cause, but immediate interventions are our priorities. Okay, so positioning, providing oxygen. Okay, that's to improve our oxygenation, those two things. And then we want to decrease the fluid in our lungs. So that's where we would use those IV diuretics. Okay. Next, we want to decrease the workload on the left ventricle. We can do that with our inotropic agents, vasodilators, and then we're going to work on treating that underlying cause. So what brought that on? So that here's a few examples of diagnosis that we would see here. So impaired gas exchange. When you are caring for your patient and their oxygen's not improving with just placing oxygen on them, they may need that positive pressure. So using a CPAP or BiPAP might help them as well. That decreased cardiac output, that is just our heart failing because it's not able to pump enough blood forward to meet the oxygen demands of our tissues. So our patient, again, they're going to look tachycardic, they're going to look fatigued, they might have weak pulses, they might begin to be altered. For the excess fluid volume, this is where we have that renin, aldosterone, angiotensin, that activation, and we have our fluids start to be retained and build up and back up. So that looks like in our patients, we may hear crackles, we'll see the peripheral edema, weight gain, we might see some jugular vein distension. And then for acute pain, so this could result just from that myocardial ischemia, from that workload being increased. Patients may describe it as like a chest pressure or a pain. Some people feel like with pulmonary edema, that impending sense of doom. Okay, so we want to make sure that we're assessing our patient's pain characteristics, so asking follow-up questions when they're saying that they have chest pain. Okay, so your highest priority nursing diagnosis here, going with your ABCs, is going to be that impaired gas exchange. So moving into chronic heart failure, this is a progressive conditioning. So our heart's ability to pump has just gradually gotten worse over time. These symptoms have developed slowly. The compensatory mechanisms are just masking things, and then our exacerbations are becoming more frequent. So early, what our signs and symptoms may look like is that fatigue, mild shortness of breath with activity, and then later the shortness of breath is going to be more often with minimal activity, the orthopnea, fluid retention, they just have a decrease in their overall ability to perform their ADLs, okay? And then as it progresses even further, we'll have that dyspnea arrest. They'll begin to have frequent hospitalizations from these symptoms worsening, okay? So heart failure is something that we manage, and we want to keep it at our mild levels so it's not progressing worse and we're having more and more frequent hospitalizations. Okay, so as we're progressing through these, we're going to start, their initial symptom they may notice is that fatigue and weakness, and that is going to be from that reduced cardiac output. So we have decreased oxygen being delivered to our muscles. The exertional dyspnea, so their heart is having to increase their cardiac output during activity, and it's not able to keep up. So our lungs become congested. Then we have the progression to the orthopnea and the paroxysmal nocturnal dyspnea. So they're having fluid redistribute whenever they're laying flat, and that might cause making it harder to breathe for them. A lot of these patients need to sleep sitting up on multiple pillows. They might sleep in a recliner. But with that paroxysmal nocturnal dyspnea, this is whenever they'll kind of wake up with a jolt, gasping for air. So just sudden nighttime breathlessness is what that means, okay? They'll develop a cough because of that fluid accumulation irritating their lung fluid or their lung tissue. Crackles, again, we have that from that fluid in the alveoli that's giving us that crackling sound. From the pulmonary congestion. Tachycardia, we're going to see that as we're trying to compensate for our decreased cardiac output. The chest pain they can have from the ischemia that's happening. So we want to remember that our Cheyne-Stokes respirations, that's where we're having the rapid respirations with our period of apnea, and this is going to be our more advanced heart failure stages. Edema, we see that from our fluid retention and our venous congestion, so we'll see that edema in dependent areas. Things like anemia, so we're already having poor perfusion, but also the fluid accumulation is kind of like diluting the oxygen in our blood. Okay, the nocturia, so when lying down, your fluid's gonna return back into your circulation, so that extra fluid being filtered through the kidneys, causing the nocturia. The cyanosis will be seen with our late stages of hypoxia. So our bluish discoloration of our lips, altered mental status also from the hypoxia, just our decreased blood flow that's going to our brain, and then malnutrition. So heart failure really increases our metabolic demands, but we have decreased perfusion to our GI organs. So our patients might complain of things like just a poor appetite, early satiation, okay? And it's whenever you already feel full throughout from all that extra fluid, you're just not, you get really fatigued during meals. It's just hard to keep eating. Okay, so moving into the complications of chronic heart failure. So one of my best friends growing up, she had a lot of congenital heart defects, and although these were repaired surgically whenever, she was a baby, in her early 20s, she had a lot of issues with just fatigue, and that took her in, and then they eventually learned that she was in heart failure. So her heart failure now, 10 years later, she's able to manage it, but it's progressing to where she's now in liver failure. So what that kind of looks like for her is as that so left side failed, caused right-sided heart failure, and that right-sided heart failure causing all that systemic congestion caused the increased pressure through her hepatic blood flow. Okay, so that caused a lot of enlargement. So kind of the day-to-day for her, she doesn't know what size of clothes she's ever going to wear whenever she wakes up. It's all on, how her body did overnight with, removing fluid and, where her medication regimen is at. But she has a lot of abdominal fullness from that liver failure now and enlargement. Very poor appetite. She has a lot of nausea. She has a lot of issues with her breathing at night as well, that paroxysmal nocturnal dyspnea that we talked about. Pleural effusions, those are going to happen just from that leaking of fluid into your pulmonary circulation. So the thrombosis and emboli from that poor cardiac output and our just slowed circulation, we're going to have blood clots that can form. So as our mobility reduces and we have that venous stasis, we're at an increased risk for clots. And then lastly, cardiogenic shock. So that's going to be when our pump has just reached an overall failure. Okay, we can no longer maintain perfusion to our vital organs. Symptoms of this will look like severe hypotension, altered mental status, cool, clammy skin, decreased urinary output, weak pulses, so a lot of your poor perfusion signs. Okay. So diagnostic tests are, I'm not so much worried about you looking at numbers, but knowing just what our test is testing, okay? So our BNP, that is released from our ventricles when they're stretching due to that overload. So as our ventricle pressure increases, we have more myocardial stretch, and so that BNP is going to increase or release and be higher. So whenever we're above 400, usually that is indicating heart failure. And so next are BUN and creatinine. As our renal perfusion decreases from that cardiac output, we'll have an increased BUN and creatinine. Okay. Next are liver function tests. So those might be elevated from that right-sided heart failure causing the hepatic congestion. Okay, so we can expect like an elevated AST and elevated ALT. Our thyroid function. So uncontrolled thyroid disorders can worsen heart failure. So whenever your patient is hyper, so with an E, that would be an increased workload. Everything speeds up. So expect that with hyper, increased workload. Hypothyroid, hypo with an O, so decreased cardiac function. Our ferritin, we're looking at that just with the iron deficient anemia that can worsen our fatigue and reducing our oxygen carrying capacity. We're looking at a chest x-ray, looking for cardiomegaly, pulmonary congestion, pleural effusions. Our echocardiography. Here we're looking at our heart structures, so our heart size, the wall thicknesses, our ejection fraction, how our valves are functioning, how our blood flow through that heart is looking. The electrocardiogram, going back to the echo, so whenever our ejection fraction is less than 40, that's going to indicate that we have systolic heart failure. Alrighty, so then our echocardiogram, that's evaluating our heart rhythm, any conduction abnormalities. It can show us if there's evidence of ischemia. Um, Exercise stress testing. This is evaluating our cardiac function during activity and our exercise tolerance. It can also indicate if we have any ischemia. Okay, so this is going to help us determine if our heart is meeting increased oxygen demands. Cardiac magnetic imaging, so cardiac MRI, that's going to look at our myocardial structures, looking for any scarring, cardiomyopathy, more detailed tissue damage. A cardiac catheterization angiography, so we're looking for coronary artery blockages, looking at the pressures within our heart chambers. And then sleep studies. So sleep apnea is pretty common in heart failure patients, and treating that sleep apnea can actually greatly improve our heart function and reduce that heart failure progression. So our therapeutic intervention goals, our overall goal is to improve our heart's pumping ability and decrease the heart's oxygen demands. So we want to try to identify and correct our underlying cause. So how can we, meet those goals of improving the pump and then decreasing the oxygen demands? Usually we learned it from the beginning that one of the most common causes of heart failure is hypertension. So if we can correct that hypertension and control it, that can help treating any coronary artery disease. If we have a valve disorder, correcting that. If we find that we are in a dysrhythmia, correcting that as well. We want to increase the strength of our heart's contraction, so making our pump more efficient. We can use medications to help with that forward movement of blood and reduce that congestion. Maintaining optimal water and sodium balances. We can do that by managing our fluid, whether that is doing a fluid restriction, using medications to help reduce the fluid, preventing edema, reducing that pulmonary congestion, decreasing the workload on our heart. Okay, so to decrease the workload on our heart, we want to lower our blood pressure, reduce our preload and our afterload, control our fluid volume, and then slow down our heart rate. And we can do a lot of these things with medications. So on your blackboard, I've put 2 tables, and we will go over these 2 tables in person in our lab tomorrow, just to make sure that you have everything. You'll kind of compare and contrast what you have with the people that you'll be working with. So for our medication therapies, we have oxygen on there. Oxygen isn't going to fix our pump problem, but by placing oxygen on our patient, we can help improve our oxygen delivery to our tissues throughout. So for ACE inhibitors, we want to think like lisinopril. Our ARBs, we can use the example of losartan. And then your ANRIs, those are going to be a combination of an ACE and an ARB. I think sacubitril, I can't say it. And valsartan is a common one. The brand name of that is Entresto. So these work by blocking that renin-angiotensin-aldosterone system. Okay, so how these are going to help us is they're going to reduce our vasoconstriction, reduce fluid retention, decrease our cardiac workload, and slow that heart remodeling that happens from that overworking. Okay, so one thing I want you to know, your ACE inhibitors are your first line therapy for your chronic heart failure. Okay, so overall kind of goal of these is just working more efficiently and slowing down that disease progression. Next, we have our beta blockers. So some examples of that is your metoprolol and your carvedilol. So they're reducing the effects of our sympathetic nervous system stimulation. Okay, so they're going to help to decrease our heart rate. decrease that oxygen demand, and allow, by decreasing our heart rate, allow for improved ventricular filling. Okay, so beta blockers are going to slow our heart rate and allow our pump to pump more effectively. Alrighty, our diuretics, some examples are furosemide and bumetanide. These are going to help remove any excess fluid from our body, and that fluid decrease is going to help decrease the preload, reduce pulmonary congestion, improve our breathing, and reduce edema. And so they improve, this is more of your symptom improver. So next, inotropic agents, so things like digoxin and dopamine, they're gonna increase the strength of the heart's contraction, okay? So it'll improve your cardiac output in your patients with severe heart failure. Okay, so a thing to know about your digoxin is that it can become toxic, so we want to monitor our levels with that. Alrighty, vasodilators, so our nitroglycerin and our hydralazine. Okay, so these are going to decrease our vascular resistance, so reducing that afterload, decreasing the workload on the heart, and improving that forward blood movement. Okay, so if there's less resistance that our heart has to work against, our blood can pump through the heart easier. The ivabradine, so this is a newer drug, I've never given it, but it works by slowing our heart rate at the SA node. So this is going to be used whenever a beta blocker isn't getting the work done for you, okay? So you have kind of that stronger, that big guy to come in. Alrighty, our anticoagulants. So we know that our heart failure patients are at an increased risk for clot formation. So we want to help prevent those DVTs, the pulmonary embolisms. So examples of those can be our warfarin. We have the DOACs for our direct anticoagulants. So like our apixaban, and then our what's the other name for Xarelto? Let me look it up. So the Xarelto is the rivaroxaban. I can never remember that one. Okay, so just trying to keep, I think the table will help try to keep these on, here's common names, here's, what I need to monitor, which we'll talk more about tomorrow, and then how it's working. Alrighty, you also have a table in there for your therapeutic interventions. And we just want to talk about how those are going to help our patients with heart failure. So activity, why that matters is it's going to help improve our circulation and strengthen our overall cardiovascular system. Okay, so balancing that activity with rest is important for our heart failure patients. So we want to make sure we teach them to rest when fatigued and just moderate exercise as tolerated. Next, our sodium and weight control. So excess sodium is going to cause more water retention, which is going to cause our fluid volume to increase and worsen our heart failure. So that's why our patients will usually be on a sodium restriction and a fluid restriction as well. We want to do daily weights with our patients, so teaching them to report a 2 to 3 pound gain in a day, and then more than 5 pounds in a week. Okay, so 2 to 3 pounds in a day, more than 5 pounds in a week. That weight gain is going to be one of our earliest indicators that we're having fluid overload. So a pacemaker, that's going to help us to regulate our heart rhythm and maintain an adequate heart rate. Our implantable cardiac defibrillators, so our ICDs, that's going to help monitor our heart rhythm and deliver a shock if we do go into a dangerous arrhythmia. Okay, so our heart failure patients, they are having a higher risk of these life-threatening dysrhythmias. Cardiac resynchronization therapy, so that's going to synchronize the contraction of the left and right ventricles, so that's going to help to improve our pump. Okay. Mechanical assistive devices. So when our medications and our standard therapies are no longer helping, we'll move to these. This intra-aortic balloon pump, we have a picture of it coming up and I'll tell you more. But this is just a balloon that's placed in the aorta and it's going to inflate and deflate with each heartbeat. So that's going to help to improve that coronary perfusion. Ventricular assist device, we also have pictures of those. That's going to be a mechanical pump that helps our ventricles to move the blood forward. Okay, so that's going to be used in your severe heart failure, and it's usually used as a bridge treatment if you're needing a transplant. The total artificial heart, implantable replacement heart, we're going to use these whenever our heart's pumping action is failing. So our end-stage heart failure and when our other treatments are no longer effective. So we'll move forward to our picture, this intra-aortic balloon pump. So what I want you to know about it is it's assisting our heart whenever our pump's ineffective. So it works by inflating during diastole and then deflating during systole. So that's going to help improve that coronary blood flow and decrease the workload on the heart. Okay. Alrighty, our ventricular assistive devices. So they're going to help the pump action of the failing heart, so circulating the blood throughout the body. So some devices are like the aortic pump, that's going to be like a temporary assist, but our ventricular assist devices, they can be used pretty long term. Okay, so this is going to be your long-term support for your patient that is in end-stage heart failure, and it's used as their bridge to transplantation. Or if they are too sick for a transplant, this just might be their only option. This is their destination. They're, with it for the remainder of their life. Okay. So it allows your advanced heart failure patients to live longer and to maintain a better quality of life. This is a quality of life device. Okay. So it's not going to replace it entirely, but it can take over a lot of that heart's pumping function. Okay. I think I have a picture next. Yeah. Okay. So this is of our left ventricular assist device. So it's going to pump, it's a mechanical pump that helps the left ventricle circulate blood when our heart's pumping action has become too weak and ineffective. So the blood's going to enter the LVAD from the left ventricle, and then that's going to pump the blood up into the aorta, sending oxygenated blood to the rest of the body. Okay. It's implanted inside the chest. Things that we want to teach our patients about these is these run on batteries. Okay. It's an external battery that's worn by the patient. We want to teach them to carry spare batteries with them, to always have, their batteries charging. And it's a continuous, it is always with you. For your heart to pump effectively, you need to have continuous battery power going with this. Okay. So think of this as your bridge to transplant, or it can just be your long-term therapy for your patients that are not transplant candidates. Nursing considerations with this is not no longer like a pulsatile blood flow, it's a continuous blood flow. So your patients, whenever you're checking their pulses, they may not have a pulse. It may be absent or just may be very weak because that's, that continuous blood flow. We don't have the pulsatile action. Okay, so the heart's still present and functioning. We are just kind of using this mechanical helper. Alrighty, surgical interventions. We can do coronary artery bypass grafting. This is referred to as a CABG or just bypass surgery. It's where we are, so where we are harvesting vessels from most often our leg to create new path flows for our blood to go around those blocked coronary arteries. Okay, so you're harvesting vessels from another place to create a new pathway of blood flow. Okay, so that's going to help increase the oxygen delivery to your heart muscle and improve heart function. Valve replacement, we're going to use those when our heart valves are damaged, not functioning properly. So stenosis is whenever our valves are narrowed, and then regurgitation is leaky valves. Okay, so whenever those issues are going on, we need our heart to work. Our heart's having to work properly. Our heart's having to work harder to work properly. We want to fix those valves. Ventricular reconstruction is whenever we have part of our ventricle that's damaged or weakened. Often, like after an MI, a surgeon can go in and help to reshape or remove the scarred portions of the ventricle. So that's just going to help that contractility be more effective. Okay, so these procedures are going to be aimed at improving our blood flow through the heart, correcting valve abnormalities, and then just restoring more effective ventricle function. Alrighty, back to our nursing diagnosis. So I'd make notes on these for whenever you're working on your care plans. We see a lot of heart failure. So impaired gas exchange, that's going to be one of our most common problems in heart failure. So we have that because of that fluid leak into the alveoli, interfering with our oxygen stage. Okay, so you might observe things like shortness of breath, crackles in the lungs, low oxygen saturations, cyanosis, nursing focus, focus on positioning to improve oxygenation, administering oxygen if necessary. Okay, just monitoring the respiratory status. Decreased cardiac output, so our heart failure is causing decreased cardiac output because that pump is just not effective enough to meet our body's needs. So this will lead to reduced perfusion to target organs and tissues. Okay, so your patient may express fatigue, weakness, you may see hypotension, cool, pale skin, decreased urine output from that decreased cardiac output. So we want to focus our interventions on monitoring their vital signs, administering medications to improve their cardiac output, and assessing perfusion and organ function. Acute pain, we talked about that acute chest pain from ischemia. Okay, so it can be from coronary artery disease or myocardial ischemia, but that pain is going to increase the stress on our heart. So we want to assess our patient's pain characteristics, administer medications to help alleviate that pain, and monitor their cardiac status. Anxiety, a lot of anxiety from that shortness of breath, hypoxia, fatigue, and just the overall fear of your symptoms progressing. Okay, anxiety is going to increase our heart rate, And so that's going to increase our oxygen demand, which is going to further stress that heart. Okay. So we want to focus our care on providing reassurance and explaining things in plain language. Okay. We want to promote and teach breathing exercises, relaxation techniques, excess fluid volume. So we have that fluid retention from that renin-angiotensin-aldosterone system. Okay, that's causing our body to retain more fluid. And sodium. So as the nurse, you may observe peripheral edema, pulmonary congestion, weight gain, jugular vein distension. Our nursing care, we want to monitor their daily weight, assess their edema, track their intake and output, and then administer any diuretics as needed. Okay. Alrighty, so nursing interventions, we went through a lot of those, relating them into the diagnosis to try to put the big picture together. But our nursing interventions: oxygen, rest and activity, positioning to promote oxygenation, our fluid management, reducing oxygen consumption, so maintaining our conserving our energy, medications, and teaching about our medications. That's a thing that I want to fill in on our table. What do I need to know to teach my patient about this medication? A low sodium diet, weight control, and also doing the daily weights, education, and then coping as well. Teaching your patients in plain language why they need to do the things that they need to do is going to help them be more compliant. Okay, you can't expect your patient to do things that they don't know what you're talking about. And that's why I'm such a big advocate about knowing, like meeting your patient where they're at. Our health literacy in Kentucky is at an elementary school level. So think of it as explaining it in language that an elementary school student would understand. Okay, I think that's a big part of educating your patient, making sure that they understand the education that they're receiving. Because if they're not receiving the message, then your message, really is ineffective. Okay, so I'm going to skip over a few of these case study slides because I want to go over them tomorrow and just kind of make it a more broad how we need to be contacting our physicians, because that's something, well, not our physicians, our providers. Communication with the SBAR format is very important, and that's one thing that I want to go over and practice in lab tomorrow. Okay. So we'll look over these and prepare them tomorrow, but I want you to, know that we need to identify ourselves, who we're talking about, identify our patient, have, our patient identifiers that our provider can use to quickly look up our patient, explain our situation. They have several patients, okay? Their workload is even, greater at night too. So we need to make sure we're quickly identifying ourselves, identifying our patient, giving them kind of the situation, what brought them in, why you're calling, okay? Giving them a background. Alrighty, so then your assessment of the situation. What is in front of you right now? You've already assessed, you've already taken new vitals, you have listened to your patient, you've put hands on your patient. Okay, we're calling after that point whenever we have all of our information. And the person you're calling, they're not in the room with you. So sometimes at first you're not going to know what you need to recommend. So you'll learn this with your preceptor. You'll learn this during, what's the word? Practicum, that's the word I couldn't think of. Okay, so you're going to work with your nurse during your practicum. So you will know the things to recommend. All right, so Whether you need somebody to come to the bedside, you can recommend that. Whether you think you need different medications, like a PRN medication to administer to help alleviate their symptoms, okay? But the last part, the second R, is always read back. Before your provider hangs up, you want to say, okay, so let me make sure I have this straight. I've written it all down. Our plan is to XYZ. I'm going to put on 2 liters of oxygen. I'm going to give this medication in case their blood pressure gets over this level. I'm going to call you back if I'm seeing this. Make sure that you both are on the same plan, okay? All right, going through a few more. Okay, cardiac transplant. Okay, so this is whenever we are at end-stage heart failure. All right, we have criteria that we need to meet. It's very strict. So we need to look at the patient's overall physical health. All right, are they absent of a severe infection or cancer? Would they survive the surgery? What's their, ability to tolerate a major surgery at this point? What is the likelihood that they are going to follow these, immunosuppressive therapies, and then you have to take lifelong anti-rejection medications. So what has your patient's, what's the word I want to use? Compliance. So is your patient, do you have a compliant patient, or do you have somebody that, is not taking their medications, doesn't know what medications to take when? What's our trajectory here? Do we have the best chance at long-term survival? Okay. So we have to, those immunosuppressive therapies, we have to suppress our immune system just enough to prevent rejection, but also make sure that our patient's not going to get an infection that prevents them from being a candidate. So it's kind of finding that happy balance. Okay. But we need, our immune system's naturally going to recognize any kind of transplanted organ as being foreign, and they'll try to attack it. Okay, so we have to take that lifelong anti-rejection therapies. Okay, and we know that with this immunosuppressive therapy, again, we need to do things to educate our patient about infection prevention. Alrighty, so this is showing us different steps in the heart transplant surgery. You don't need to know much about this. So we have our first step here, and this is just whenever the patient's going to be placed on a cardiopulmonary bypass. Okay, so you see that the large vessels connected to tubes that lead to a heart-lung machine. Okay, then we're going to, in step 2, remove the diseased heart. Okay, we leave some structures, which you can kind of see in that third picture, to attach the donor heart to. Okay, so donor heart in the third picture, it's prepared, and we're going to align that donor heart into those structures of our patient's heart that has been removed. Okay, so next, in step 4, we are suturing the donor heart into place, connecting the atria, the major vessels. Okay, and then once we are sure that all of those connections are made, we can now set the heart up to receive blood flow and to start beating. Okay, so temporary pacing wires are going to be placed in there to help regulate our heart rhythm after the surgery. And then in step 5, we have that new heart functioning. As that heart begins to pump effectively, our patient's gradually going to be removed from the heart-lung bypass machine. Okay. So the things that we want to monitor our patient for with this is signs of organ rejection, infection. We want to monitor their cardiac function, and be on the lookout for any complications from the surgery. Okay. So to prevent rejection, we have those lifelong immunosuppressants that we need to take. Signs of rejection that we want to be looking for is things like fatigue, shortness of breath, fever, decreased cardiac function. Okay, so these patients, they're getting a lot of labs done, a lot of imaging. Okay, infection. So our nursing focus, we want to monitor for any signs of infection, maintain strict infection control practices, and educate our patients and their families on infection prevention. So malignancies, lifelong immunosuppression can cause an increase in certain risk of cancers, things like lymphomas and skin cancers. Other side effects of the anti-rejection medications, we can see kidney damage, hypertension, diabetes can occur, and just overall an increased infection risk from the immunosuppression. Okay. Alrighty, and then our postoperative cardiac surgery diagnoses, we have our acute pain, ineffective airway clearance, impaired gas exchange, risk for infection, and then deficient knowledge. Now we'll move into a case study with a concept map attached to it. So we have Mr. Reyes, who is a 65-year-old with heart failure that was diagnosed 3 months ago by his healthcare provider. He received a referral to a dietitian and a heart failure clinic where he is being seen today. So today he comes in, he has dyspnea, a weight gain of 4 pounds, bilateral pitting ankle edema, and has trouble sleeping at night, so he's often been sleeping in a recliner chair. He's 50 pounds overweight, inactive, drinks 2 beers per day, and quit smoking 5 years ago with a 40-year pack history. Alrighty, so a little more about him. He has a 5-year history of hypertension, high cholesterol, and a family history of cardiac disease. He retired early from his job as an industrial mechanic due to his heart failure. He lives with his wife and 2 children. He lives with his wife and has 2 children who are within an hour away. With his new heart failure diagnosis, he reports feeling overwhelmed with the many challenges and changes to his lifestyle. So our nurse asks what questions he has to help with developing a teaching plan. Alrighty, so we have this concept map that helps us address these things with us. So I'm going to skip. So this is where I want you to really think about that plain language, and is our patient understanding the message that we are trying to teach them? So words like perfusion, okay, oxygenation, dyspnea, orthopnea. Can we make this more plain language? So one thing that I want you guys to practice is trying to explain, and if you can explain these things in plain language, you're going to be able to talk yourself through test questions easier, okay? So knowing the vocabulary is going to help you in being able to explain it in plain language, okay? I hope that kind of makes sense on expecting things at a higher level with 204 that we kind of talked about, that Miss Noel talked about on day 1, about how the things are going to be, are you able to connect the dots now? Okay. Alrighty, so lastly, we have some review questions that we can go through. So the nurse evaluates a patient that's exhibiting the classic symptom of acute heart failure. So acute heart failure, also known as pulmonary edema. So we know that the pink frothy sputum, okay, is that classic symptom of acute heart failure. Alrighty, nurses reinforcing teaching to the patient on heart failure. We want to evaluate if our patient's understanding, and the patient states which of the following, sorry, I have a lot going on in the background, hang on. Okay, sorry. So nurse is reinforcing teaching to the patient on left-sided heart failure. The nurse would evaluate the patient as understanding. So they have correct understanding if the patient stated which of the following occurs to blood flow through the heart. Okay, so we're talking about left-sided heart failure. So that is whenever we have that blood backing up from the left ventricle. Alrighty, nurse reviews the lab result of a patient who has heart failure. Which test result would be most important for the nurse to report to the healthcare provider? And that's going to be our BNP. Alrighty, nurses contributing to a plan of care. Which of the following nursing diagnosis would the nurse include for heart failure? Select all that apply. So we could expect to have impaired gas exchange, decreased cardiac output. It's mostly going to be acute pain, so not chronic pain, anxiety, and then they'll be in fluid volume overload. Okay, so not a deficit. So we would expect 1, 2, and 4. Alrighty, nurse would evaluate the patient as understanding the complications of heart transplant if the patient stated which of these. So which things are they going to say that are correct? Okay, select all that apply. Lifelong anti-rejection medication is required. That is true. Malignancies are a risk. Yes. Rejection can occur at any time. That is also true. There is not a lower risk of infection. We know that we're at a higher risk from that immunosuppression. And the anti-rejection medications have several side effects. Okay, again, I want to apologize for earlier. I know that some of you did come to class. I tried my best to try to make an alternative plan, but unfortunately that wasn't able to happen, and it has been a labor to get this recorded. But try to go through the two tables, work through those along with the lecture, and then that we can review tomorrow, make sure that we have all the information that we need to have. Tomorrow in lab, we will be working on, perfecting our cardiac assessment, what's normal, what's abnormal, okay? We'll also be looking at hypertension, doing a short lecture on that, and then working through scenarios where we have either differentiating between a hypertensive urgency and an emergency, looking at orthostatic hypotension, and then just also looking through more of our medications better. We can also review that case study that Ms. Matthews posted for us and go through our medication scenarios too. Okay, I want you to feel like you have a good understanding of this and we can clarify anything that wasn't explained best. Okay, please reach out if you have any questions about any of the material. Thanks.